Fun fact, Dr. Pulsifer is number 10 of a family of 12 children. His wife also grew up in a family of 12, and in spite of trying very hard, he has been unable to memorize the names of his approximately 90 nieces and nephews.
But I do know my children's names, so. So it's a real privilege to give this talk. It's a lot of fun, especially when I'm talking about something I love. Bone marrow transplant and stem cell therapy are a lot of fun. And I am very grateful to Sung Young for giving that lecture, because she's provided you some wonderful background that'll hopefully translate as I go through my specific issues. Now, what you will see here in my overview slide is something that looks strangely familiar. It is essentially an outline of all that you need to know about bone marrow transplantation for the boards. And specifically, essentially everything in this talk is really focused on that. We're going to be talking about the principles associated with BMT and cellular products. We're going to be talking about conditioning therapy, a few complications. Now, one nice thing is that Sung Young gave a wonderful discussion about infections post-transplant. I'm going to touch just briefly on that, but she did such a good job. Those two slides will go by very quickly. What I'll then do is talk a little bit about disease-specific indications and outcomes. Now, one thing I need to say is indications in bone marrow transplant change over time. In my career, they've changed very dramatically. So the disease-specific talks that you will hear are supposed to cover those. I'm going to give you very broad indications, and I'll talk about non-malignant indications to a degree. But listen very carefully to the transplant indications that will be in the disease-specific talks that you're going to receive. I'll then spend a little time on other non-malignant disorders and finish off talking a little bit about CAR T-cell therapy. So, collection, processing, and storage. Now, an important thing to keep in mind with transplantation is we have a very specific goal. Our goal is to transfer hematopoietic stem cells along with other things. And this is incredibly important for people to understand. It's not just the bone marrow stem cells or the CD34 cells that matter. Everything that goes along with it can matter tremendously, and we've learned over the years how important it is to really know exactly what we're doing with those things. Now, these cells, and Sung Young gave you a lot of outline of them, are important because we dose by them very specifically. CD34 cells, T cells, of course, which are marked generally by CD3. One thing that I want to give a shout out, and Sung Young mentioned it as well, is alpha-beta. CD3 cells are important to understand as well, because some of our depletion procedures only take out alpha-beta CD3s. B cells, of course, are marked by CD19. It's important to understand that they're also marked by CD22 and CD20, and we have antibodies that are targeted against them, and so it's really important to know your B cells. NK cells, of course, as Sung Young mentioned, are marked with CD16, CD56, or both. Cell numbers that are really key in choosing doses are CD34 cells, and they're dosed according to recipient kilogram weight. Now, they're harvested sometimes according to donor weight, so keep that in mind. Recipient weight is very, very important. In addition to that, total nucleated cells are another way of dosing, but that's really restricted to cord blood. Now, this is a picture of how we obtain the traditional source for a bone marrow transplant, and that is a true bone marrow. On the back of your hip is your posterior iliac crest, and there's only one purpose for that: bone marrow harvest. Seriously, it doesn't have any muscles attached to it, no nerves nearby, no major blood vessels. It's really a wonderful, wonderful place. And if you've had an opportunity to participate in a bone marrow harvest, you've gotten incredibly familiar with it. One harvest will give you all of the bone marrow experience you need to have to suit you through the rest of your careers. The other two sources are obtained by some of the illustrations that you see here. This is an apheresis machine. This machine, of course, is attached to the patient, and white cells are apheresed and collected. This is a picture of a placenta dye injected, and what you can see, of course, is that there's a fair amount of vasculature there. When those placentas come out and they're clamped, there's approximately 100 cc's of blood that is there, sometimes more, sometimes less, kind of depending on what position the baby's held in, high or low. When the placenta is taken, they can then be harvested for remaining blood. And that blood is highly enriched in CD34 cells that are very potent because it's from a newborn baby and can be used as a stem cell source. So let's talk a little bit about what you do with those stem cells, about processing, because you have to keep in mind that you can't just put cells in, you have to know what you're doing. The first and most important thing to keep in mind with bone marrow transplantation and putting in cells is ABO incompatibility. I think it doesn't take a lot of thought to understand that if you put in a red cell type incompatible bone marrow, you're going to run into trouble. And of course, incompatibility in this case is going to be defined as major incompatibility of, say, A into a B or A into an O. This, of course, can cause very severe transfusion reactions. So, of course, when you need to do this, and it happens very frequently, when you prepare for bone marrow transplantation, blood type is a consideration, but the most important thing, as we'll talk about later, is HLA type. So if you happen to have an HLA-compatible donor who's a different blood type, don't worry, you're going to give your recipient a new blood type. It's okay. But you do have to get the bone marrow in without hurting it. So if you have incompatibility, then you will take those red cells out. And there are a number of ways that red cells can be removed. Most commonly, centrifugation and removing from the centrifuged thing, the white cell layer, and using that white cell layer. In addition, when you have a minor mismatch, then you're going to have plasma that has antibodies against the red cells in the patient. Now, that's less of an issue. You can get away with giving a small amount of plasma to patients, and maybe they'll have some red cell lysis, but it's not necessarily going to cause a big problem. Because of this, it is really center-specific about the degree of plasma depletion that occurs for minor problems with ABO incompatibility. But bottom line is, remember and keep in mind that red cells of an incompatible product need to be removed. Peripheral blood stem cells, and we'll talk a little bit more about peripheral blood stem cells, generally have a very low red cell content. And over the years, we've figured out how much patients can have. Now, you won't be asked that on the board. It's way too complicated. But do keep in mind that giving peripheral blood stem cells is a lot easier if you have patients who have ABO incompatibilities, even a small, because only a very small amount of red cells will go into that patient, and usually we just tolerate that. But keep it in mind also that if you're informing your patients that they're getting PBSCs and they get some red cells that are incompatible, they're going to lyse those red cells and they're going to have blood-tinged urine, which is something they ought to be warned about. Cryopreservation. When do we do it? Why do we do it? And how long are these cells good for? So first thing to keep in mind is that essentially 100% of patients who undergo autologous transplantation have cryopreservation because they're collected very early in their course. And the reason why they're collected early in their course is that intensive and sequential rounds of chemotherapy can deplete bone marrow stem cells. So the best strategy for this is, as soon as you know the bone marrow is clear, collect those patients, store them by cryopreservation. Cryopreserved products can last for a long, long time. We know they last at least 30 to 40 years because we've been doing it for about 30 to 40 years, and as we're thawing them out over time, we're knowing that we're getting good and viable cells that you can use for an extended period of time. Now, when you preserve them, they're generally preserved in DMSO. You need to inform your patients about what's going to happen when you get a load of DMSO. And keep in mind that too much DMSO is bad for you. It can cause hypo or hypertension and other sometimes very significant reactions. So again, the stem cell labs that anyone of you would be working with will have very strict guidelines about how much DMSO you can give based on the patient's body weight. DMSO can also cause a bitter taste when your patients are getting it. They're going to have a nasty taste in the back of their throat, and they're going to have bad breath for a couple of days. In fact, some people can't stand being in the room with DMSO. It's kind of genetic. Some people can smell it, some people can't. But that smell will go away after a couple of days. When do allogeneic products need to be cryopreserved? In general, the goal for an allogeneic product from another donor is to give it fresh. And the reason why is because we think it just works better. However, there are a number of circumstances when it's important to cryopreserve. And one is, let's say you're doing this from international donor and you simply don't have the ability to get it to you in time because of some problem or complication that's occurred. You can get that product cryopreserved and shipped to you, and you won't have to worry about it expiring. We should infuse, I prefer to infuse all blood bone marrows within 48 hours. 72 hours is the limit according to the National Marrow Donor Program. But bottom line is bone marrow that's harvested and sits around for a period of time is going to have cells deteriorating. And so you'll need to cryopreserve it if you can't get it quickly. That also comes up with schedules with donors. On occasion, your donors simply can't line up, and maybe they're your only donor, and under those circumstances, then cryopreservation will need to occur. Let's talk about types of manipulation that can be done, again, with processing. First, CD34 selection. There are a number of different ways to decrease graft versus host disease through T-cell depletion. I think all of you know already and understand that T cells are the source of graft versus host disease, and that excessive T cell activation can be a real problem. So one of the methods of in vitro T cell deletion is to take a harvested PBSC product, preferably, and do a CD34 selection. Using current methods, we can get high concentrations of CD34s. Now, the challenge with this is that it removes all of the cells. These products can be 99.9% pure with only a very small fraction of non-CD34 cells. So you've taken everything else out: monocytes, macrophages, B cells, all sorts of cells that could potentially help the patient. They've been removed. And so because of that, patients have very slow immune recovery when they have this particular type of selection. With that in mind, a number of different iterations of T-cell depletion have occurred over the years. CD3 depletion first, then CD3 and CD19 depletion after we learned that taking out CD3s and not taking out CD19s led to excessive EBV lymphoproliferative disorder. And finally, alpha-beta CD3s, because the bad guys are not the gamma-delta CD3s, they're the alpha-beta CD3s. Those are the ones that really cause graft versus host disease. So many programs who are using T-cell depletion are using alpha-beta CD3 and CD19 combination depletion. Over the years, this has led to decreased transplant-related mortality and better immune recovery compared to some of the earlier selection processes. New methods are being tested. One specifically is CD45RA depletion. Now, it's unlikely you're going to get all this detail, but the key thing to keep in mind about T-cell depletion is it takes time for the immune system recover when you take the T cells out. So you do pay a little price for your decreased rates of graft versus host disease. There is, along with transplant, in vivo T-cell depletion. Again, something very important. Serotherapies of various types have been given. You can have horse or equine ATG, rabbit ATG, and alemtuzumab, which is anti-CD52. All of these deplete T cells very intensely and specifically and can decrease graft versus host disease. And finally, new kid on the block is post-transplant cyclophosphamide, which I'm sure many of you have heard about as a very nice way of decreasing graft versus host disease. Let's talk a little bit about storage of stem cells. This is something that's very important for you to understand, and again, new on the boards. For transplants, fresh cells that are removed and then going to be infused in the patient are transported cool. So this is the classic picture, you know, on your pop medical television series where you've got your organ in the little cooler and you're walking around. They do that with bone marrow transplant as well. And it's not frozen, it's just transplanted cool in a little cooler. But if you need to transplant frozen cells, they need to go through regulated shippers, and people are incredibly meticulous about this. There is continuous temperature monitoring. When it arrives at the center, they look and make sure that it kept the temperature the entire time, because the last thing you want is for your stem cells to thaw at 35,000 feet and be dead by the time you land. So when they're transported through careful and specific mechanisms. Now, in the stem cell lab, when these products are frozen, they, of course, are stored in liquid nitrogen tanks. A minor difference between liquid and vapor phase. Patients who have potential HIV or hepatitis B or C, there's a theoretical risk of transfer of those particular viruses through a liquid phase, and therefore if patients could ever potentially have any of those infections, they're generally stored in a vapor phase, so just above the liquid nitrogen. It's a minor detail. I'm sure it won't be on the boards, but a key thing to keep in mind. They need to be continuously monitored, and again, the cells are viable for a long, long time. Now let's talk a little bit about the three stem cell sources. I put these other two stem cell sources as possibilities, but I don't see them on the horizon in the next 5 years. Maybe in the next 10 years, we may be looking at iPS cells that we can use in order to do transplantation. And fetal liver isn't even close. But umbilical cord blood, bone marrow, and cytokine-mobilized peripheral bone marrow cells. When should we be using each one of those particular types of cells? First, for autologous transplantation, there's no doubt there's an easy winner. You don't even need to think about it. Always autologous is given with peripheral blood stem cells. And the reason why is patients recover very quickly, and it's made autologous transplant a very safe procedure. In the era when we were doing bone marrow harvests on these kids, we had difficulty getting adequate stem cell doses. They recovered slowly, they had more infections, and the death rate was up to 10%. Now in autologous transplantation, the death rate is well less than 1% because we know how to do this very well. So it's very clear that peripheral blood stem cells for autologous procedures are the way to go. For allo procedures, it's a little bit different. What we've actually found is that umbilical cord, bone marrow, and peripheral blood marrow stem cells have advantages and disadvantages, and because of that, people have gotten very good at using each one of them. What you'll hear in the rest of the talk is me describing when it may, the pluses and minuses of these. There's no clear winner for allogeneic transplant from these three different sources. This particular chart, which I've included, is a really nice way to compare each one of those sources. And the key thing as you look at this chart in your syllabus is to remember that T cells are key. The T cell content is going to really dictate how your patient is going to do and what you need to prepare for. If you look at each one of these, peripheral blood stem cells, high T cell count, bone marrow, that's kind of in the middle there, cord blood, very few T cells, and of course T cell depleted, whether they're haplo or non-haplo, they're going to have very low T cells. So what does that mean? If you have high T cells, you have rapid recovery, normal T cells, moderate recovery, few T cells, you're going to have relatively slow recovery. Now, one interesting thing is that with T-cell depleted procedures, people have tried to make up for it by giving very high CD34 doses. And that does tend to help neutrophil engraftment come along a little faster. In addition to that, a number of people are doing cord blood expansion, either expanding part of the unit or expanding a second unit. And what happens with that is that helps cord blood to recover a little faster. So people are working very hard to try to get through, to try to overcome some of the weaknesses of each one of these things. One key thing to keep in mind, though, with peripheral blood stem cells, your risk of both acute and chronic graft versus host disease are very high. Because of that, most pediatric transplanters tend to avoid the use of peripheral blood stem cells. But sometimes you don't have a choice because your donor, especially unrelated donors, sometimes will only agree to give peripheral blood stem cells. And if they're your only match, then you have to go to it. And we have some ways around that. But keep in mind, peripheral blood stem cells are associated with higher rates of graft versus host disease, cord blood with lower, and T-cell depleted products with lower. So, doses of stem cell source. I don't think you have to know this cold. There's only really two things that are really important to keep in mind. We like to have in the neighborhood of 5 times 10 to the 6 CD34 cells per kilo for a standard either bone marrow or peripheral blood stem cell dose. For cord blood, though, and this is a more important number to keep in mind, your target is to have more than 4 times 10 to the 7th total nucleated cells per kilo. And there have been a large number of studies that have shown that cord blood cell dose matters tremendously. If you have an inadequate cell dose, your likelihood of transplant-related mortality, relapse, and non-engraftment goes way, way up. Now, if you have well-matched cords, either completely matched or only a little bit mismatched, then you can get away with a little bit lower dose. But for highly mismatched cords, you can actually make up for it by giving more cell dose. So many people, if they're going to have a number of mismatches, really push the stem cell dose, even a lot higher than 5 times 10 to the 7th per kilo. So bottom line with cord blood, and something to keep in mind for boards, is we want to have at least 4 times 10 to the 7th. And if we have that, we don't need 2 units. But if you don't have that, then you really would need 2 units in order to do a viable cord blood transplant. Now, one tiny thing just to mention with T-cell depleted procedures is in order to make up for the fact that with lower T-cells, it decreases your graft versus host disease, and it also increases your chance of rejection. Therefore, people, again, try to make up for that by giving very high doses. So rather than just 5 times 10 to the 6 CD34 cells per kilo, sometimes we're pushing it to 10 and 20. And last week I gave 60 to a little baby who we wanted to make sure it didn't engraft, make sure they did engraft. For post-transplant cyclophosphamide, one thing that we do know is if you use bone marrow, you have to really push your dose in order to make sure that you get good engraftment. So we like to have not only CD34 cells, but a lot of mononuclear cells as well. All right, now to wake you up, time to do a case. And I'll do a bunch of clinical scenarios from this point at all. So you can start thinking, you don't need to raise your hands, but come to the answer and feel good about yourself when I tell you what it really is. So we have an 18-month-old who has ALL in second remission, and they're referred for transplant. What is the best donor for this child? Is it the child's own cord blood, because they stored it when they were young? That would be pretty cool. 55-year-old female unrelated donor who's a 7 of 8 match, and doesn't matter, she's happy to give either one, marrow or peripheral blood. A cord blood unit matched out of 4 to 6 antigens and a cell dose of 5.4 times 10 to the 7th. A 40-year-old unrelated donor matched at 8 of 8 loci, but he's only willing to donate peripheral blood stem cells, or a cord blood unit that's matched at 8 of 8 antigens with a cell dose of 4 times 10 to the 7th. So the correct answer is E. And why is that? Well, you know, there's a bunch of these that could be appropriate. This is one that absolutely is not. You don't want to do an auto transplant unless you're doing someone who's supposed to get an auto transplant. We'll talk about that later. A 55-year-old female, the challenge is the older the donor, the worse outcome. And I'm this age, so I'm confessing we're bad donors. Don't use us. And it's a challenge, especially if that woman has had children, because Paris, and especially multiparous donors lead to more graft versus host disease. So keep that in mind. And of course, it's a mismatch. The cord blood unit is mismatched, but it's a pretty poor match with only 4 or 6 antigens. So you got a good cell dose. So this actually could be used if you didn't have another alternative. You're 40-year-old, you could also use that if you didn't have another alternative, but they're only willing to give peripheral blood stem cells, and so that's going to result in a lot of graft versus host disease. So in pediatrics, we tend not to use that donor. So cord blood has been shown, if it's fully matched and given an adequately cell dose, to be very good. Now let's talk a little bit about HLA. HLA, of course, is human leukocyte antigen, which is part of the MHC on chromosome 6, short arm of chromosome 6. And as you know, it's inherited just like an autosomal recessive disease, where every sibling has a 1 in 4 chance of being a match. Now, one thing that's really key to keep in mind is that the length of this particular, the distribution of these genes, you can see, is approximately to where you would have natural crossover rate of about 1%. So you may have a circumstance where you're typing siblings and all of a sudden you think you have a match, but no, they're mismatched by 1. And if it's a true crossover, you can potentially use that patient, but then you have to look closely because you have to know where your crossovers are and just make absolutely sure that it is a full match. All right, let's talk about known alleles. This is what makes transplantation very hard. When I first started showing this slide, which was about 15 years ago, there were somewhere between 200 and 400, and now we're in the 4,000 to 5,000 range of all of the different alleles around. And if you calculated the potential number of independent alleles that you could have in transplantation, no one would ever get an unrelated donor transplant because there are so many potential combinations, it's hard to even express. But because people tend to marry those people who are similar to them genetically, and because there's a lot of similarity in Europeans, it turns out that you do have a chance to match a number of people. But it's not just HLA, unfortunately, and actually I should say fortunately in this case, because minor histocompatibility complexes make the difference. It gives us the allo effect. It gives us graft versus leukemia that can help cure patients. There are a ton of minor HLA genes that are being found all the time that can cause graft versus host disease even when you have a complete match, and they also decrease risk of patients relapsing when they're present. So let's talk about how you characterize HLA. Now, I made a distinction here between matched sibling and then other related donors, and also the fact that almost everyone types by their matched sibling this way at this time. So how should we be doing typing? Almost everyone now, for patients who are in the family, who are related, who we think are matched, because sometimes you can have a father or mother who's a full HLA match just because you happen to have some alleles in common. You'll need to type them at the allele level, HLA A, B, C, and DR. Now, all you need to do if you have a true matched sibling, you know that it's a sibling, you're very confident of it, you just need to confirm that they are a match. And you can sometimes do that with low-level typing of HLA A, B, and DRB1. But most people nowadays, because the cost of typing has come down, they're actually using allele level for most everything. Unrelated cord, we used to only type 6 antigens, and some centers still do this, but there's increasing data that shows that you really should be typing 8 or up to 10. Now, how are these used? How much, what stem cell sources are we using nowadays in transplantation? Now, this is over the last few years, and it's very interesting to see kind of what was happening for a period of time and how we've been evolving. The first thing to keep in mind is that unrelated donor peripheral blood hasn't really changed, okay? That's what this little green box is. This has been the time through the years when unrelated donors have basically said, I'm only giving peripheral blood stem cells, not bone marrow. And that hasn't changed much through the years. And on occasion, centers will have good reasons to use peripheral blood stem cells as well. For example, when you're doing a reduced intensity conditioning regimen, many people prefer to use peripheral blood stem cells. But that really hasn't changed through the years. What's varied a little bit is cord blood and bone marrow. And what you can see here is that cord blood kind of peaked in about 209 and 210. Bone marrow, unrelated donor bone marrow, it was decreasing a little bit as cord blood is peaking, but all of a sudden it's increasing a little bit more. Cord blood's going down. Now, why are we using a little bit less cord blood over time? It's because of this, and what you can see here is that at about 212 through 213, when post-transplant cyclophosphamide started coming along, all of a sudden people were realizing that they could do haploidentical transplantation and could do it relatively simply. They didn't have to become experts in T-cell depletion. And because of this, this has increased dramatically, and it's increased a lot more in the last 2 years, since this only goes to 2016. So now, again, haplo is becoming a very important part of bone marrow transplantation, and we just did not expect that a few years ago, but it's one of the principal sources now. Levels of matching. This is something, just a quickie I'll mention to you. You hear blank of 6, blank of 8, blank of 10, blank of 12. All that means is you have A, B, and DRB1 for the 6. If you add C, you get 8. If you add DQ, you get 10. And if you add DP, you get 12. So that's a quickie for you to look at if you're confused about what blank out of 6 and blank out of 8 and blank out of 10 means. Now let's talk about what the right donor is. How do we get to that best donor? Because this, again, is on the boards. It's something you'll definitely have a question or two about. The most important thing to keep in mind is HLA, and forgive me for using Trump, but HLA is the most important thing. I'm trying to stay apolitical here. Single allele or antigen mismatch is all that is allowed if you are going to use an unrelated bone marrow or peripheral blood stem cells. So you get one mismatch. Don't do more than one mismatch. If you're doing more than one mismatch, then you need to treat it like a haplo. And you need to do post-transplant Cy or T-cell depletion or some of the things that we use for haplo. Cord blood, you can go with a 4 of 6 match, but there's some really nice data that was published long enough ago that it might wind up on the boards, that if you have 8 alleles, going to 6 out of 8 or 7 out of 8 is a little bit better. And again, as I mentioned before, higher stem cell dose helps with mismatches. Now, this final point that I want to make is something that we've seen time and time again, a number of publications. Bone marrow, if you're doing an unrelated donor, or if you're doing a sibling donor, bone marrow is preferable over peripheral blood stem cells. Now, this is counter to the complete practice of adult bone marrow transplantation, where they just, they have data that shows it, but they still use peripheral blood stem cells because it's just easier to do. But bone marrow is definitely preferred. This is especially important with non-malignant disorders where graft versus host disease is nobody's friend. But bottom line is peripheral blood cells, yes, it results in faster engraftment, but it gives more graft versus host disease. So we really only recommend it in pediatrics for reduced intensity regimens when patients need to have a GVL effect. Peripheral blood stem cells also are used when we're going to do T-cell manipulation. So if we're going to do alpha-beta depletion or CD34 concentration, then we're going to be using peripheral blood stem cells. Okay, this is another item that is on occasion you'll get a question about this, so I'll just mention it very briefly. It's very interesting. So screening the pediatric donor. So pediatric donors, it's very, we put these patients at a little bit of a risk, and sometimes people are very concerned about it because these pediatric donors don't have the true ability to consent. They're kind of conscripted, and all of a sudden they have to be a donor for their sibling. So we need to keep in mind a couple of basic principles. Principle number 1, we need assent. So we need to make sure that the child is willing to donate. And we need to be aware that parents are going to be very biased, and sometimes if the child is unwilling or having struggles, the parents will force the child to be a donor. So we need to deal with these issues very sensitively. This is a particular challenge if the recipient is unknown or if there's a difficult relationship, and we actually come across these issues all the time where a brother and a sister don't know that they exist because of families have divorced and separated, and they could be full brother and sister and they just didn't know that the other person is around. So we have to be very careful about how we approach this. The most important thing, though, to keep in mind about pediatric donors is this. The donor's health is preeminent and most important. The donor is innocent and the donor is healthy, and they're doing a voluntary donation, and therefore we cannot put them at excessive risk. So donors with underlying health disorders need to be carefully assessed by experts. So if a donor has an endocrine problem, if they have diabetes or something like that, they need to be assessed by the endocrine doctors and given a clean bill of health that they can have a minor surgery and do the equivalent of giving a blood donation. And if they can do that in a pretty healthy state, and those experts would agree that they're okay, then we think that they're okay. They'll also, of course, be screened for a whole series of transmissible diseases through this process. Now let's talk about a couple of other considerations for donor choice. First, if you have a choice, for example, if you have a series of siblings, one is 16, one is 18, one is 22, and the 16 and the 18-year-old are exactly the same, they're both the same blood type, they're both HLA matched, they're both the same gender, then pick the 18-year-old because they have the ability to consent rather than the 16-year-old. However, if you have a donor who's 10 and your 18-year-old donor maybe has a little bit of a health issue and they are blood type incompatible and maybe they're gender incompatible, you can pick the 10-year-old. In other words, if there's a good reason for you to pick a patient who can't give full consent, fine. But if there's not a good reason and you have a donor who can give full consent, then it's wise to use that particular donor. Another thing, blood type matching helps but isn't necessary. So again, we screen everyone for blood typing and we try to match them if possible, but it's not absolutely necessary. We CMV type, and this is another very key thing to keep in mind because you may have something coming up on this. CMV negative donors for negative recipients means better outcome. There's an increase in survival, somewhere between 10 to 15%, if you have a CMV negative donor and a CMV negative recipient. So if you're lucky enough to have a CMV negative recipient, you're going to work hard to give them a CMV negative donor if you can. In addition to that, if you have a CMV positive recipient, there's some data on both sides, but more on the side of using a CMV positive donor as well, so that as they get immune recovery, will be able to fight their CMV. Finally, gender match is actually very important. The interesting thing is, if you look at females who are prepubertal, there's probably no difference at all. In fact, I know of one paper that shows that very nicely. But other than that, what you need as people get a little bit older is you want to match male to male or female to female, and you want to avoid multiparous females. You can also, of course, do a male to female. But the big thing to watch out for, if you see it as on one of the questions, if you have a woman who's had children, then there's a definite increase in risk of graft versus host disease if that person becomes a donor. One thing also to keep in mind is donor and recipient size mismatch can be an issue, so we need to watch for that very carefully. The maximum you can take from a donor is 20 cc's per kilogram, and your goal is to provide a good CD34 cell dose for the recipient. So on occasion, you'll have a donor who's 2 and a recipient who's 12, and when that occurs, it can be a real problem. So we do some things to get around that. We give G prime for their bone marrow, or we do peripheral blood stem cells under those circumstances from the younger donors so that we know that we can collect enough to do the transplant. And I've told you a lot about the cord dose. All right, so preferred donors. First choice, matched sibling, has always been and still will be, and who knows if that'll change in the future, but the first choice is always a matched sibling. If you have a matched sibling, you should use it. Next choice, right now, we think it is a fully matched unrelated donor, but you should understand that there are current studies where a haplo is being compared with a fully matched unrelated donor because we think they may be the same, because we've gotten so good at doing haplos lately. In addition to that, cords have been shown in many studies to be equivalent to unrelated donors as well. But still, the majority of centers would say if you have a completely matched unrelated donor, then they would go with that as next. One thing you have to keep in mind also is if you have a sibling that has that crossover, you remember I mentioned that a small percentage of siblings can be a single antigen mismatch. Those look exactly like a fully matched unrelated donor, okay, as far as their outcomes. In other words, the outcomes, the survival's the same, but you can have a little more graft versus host disease, so you have to keep that in mind. The remaining donors, mismatched cord, mismatched unrelated donor, haploidentical donors, they're called alternative donors, even though we think now their outcomes are about the same. Okay? All right, got a question. I used to have pictures, but the ASPO people looked at them and said, maybe they belong to a real person on the net, so they took them away from me. Fraternal twin, identical twin, okay? Who's the better donor? So you can think about that one. Who's the better donor, a fraternal twin or an identical twin? So there's only one circumstance where you'd ever use the identical twin, and that's if you had a patient who needed an auto transplant for something like neuroblastoma, and for whatever reason you couldn't get enough cells. You could harvest them, because when you give a bone marrow transplant from a syngeneic twin, you're giving an auto transplant. Okay? You're not going to get any GVL effect. So that's the only time. So I want a fraternal twin, but of course they have to be HLA matched. And nowadays, they don't have to be HLA matched perfectly, because you can use them as a haplodonor too, if they happen to be a half match. So the fraternal twin is what you want for your bone marrow donor. All right. This is an important thing to talk about. You're supposed to know and understand contraindications to transplant. The key thing to keep in mind is this. There are major increases in risk that occur with pre-transplant comorbidities. And here's the reason why. Active inflammation or infection can lead to increased graft versus host disease and other transplant-related complication. So keep that in mind. Another key problem is prolonged neutropenia, when patients do not recover. We want patients to have some period of time with neutrophils prior to transplant so that they can be infection-free going into transplant. And if they do not recover and have had neutropenia for 4, 6, 8 weeks, they're going to be at very high risk going into transplant. Non-remission, of course, goes without saying. It's not a good thing when you're going to transplant. Even MRD positivity at many levels markedly increases your risk of failure after transplant. Underlying organ damage, I've listed here what we usually have. These are cutoffs for myeloablative transplantation. We want to have patients who have good organ function. There are transplants, of course, that are designed, reduced intensity and non-myeloablative transplants that can focus on this. Poor performance status always has been a contraindication to transplant, or something that markedly increases risks. Psychiatric disorders for sure. That includes being a crazy teenager. And the following thing, this is what I mentioned earlier, reduced intensity regimen approaches can be tailored to overcome some of these problems. This is a diagram of the concept of myeloablative versus reduced intensity versus non-myeloablative transplants. And I hope you all have had enough exposure to with your transplant teams to get a little flavor of this. The key here is patients with myeloablative procedures have irreversible pancytopenia, and they absolutely need to have stem cell support. Whereas if you just got a preparative regimen with a non-myeloablative patients, you'd recover fully from it. So again, there are a degree of support, and what happens is this uses a combination of graft versus leukemia effect plus intensity, and that's been shown to give the best outcomes in pediatrics. Whereas the non-myeloablatives are designed for patients who have significant comorbidities, and you're relying solely on graft versus leukemia effect or immunologic effects in order to do the work of making a patient not relapse. Now, we're supposed to talk a little bit about allogeneic preparative regimens. I'm going to go over this very quickly. In general, for myeloid diseases, busulfan-based regimens. For lymphoid diseases, TBI. Now, I put in here that there's a prospective trial from the IBFM that's testing whether TBI is important or not. And we've had lots of data for many years suggesting TBI is, and that particular protocol has shut down. It hasn't been reported yet, but it's shut down because TBI, yes, is incredibly important in ALL. So we knew that before, and we've learned it now with a randomized trial. For non-malignant disorders, the regimens vary tremendously, and the goal with non-malignant disorders is to use the least intense regimen possible. And most of the regimens that are used are kind of in the middle, using reduced intensity approaches. Many disorders, and here's a very important 2 disorders to understand because you might get questions about them. Fanconi anemia, incredibly sensitive to radiation. Our typical doses of radiation are in the 12 to 1400 range. We won't give a Fanconi anemia patient over about 300. They really can only take about a quarter of the intensity that any other individual can because of their exquisite sensitivity. SCID, as Sung-Young mentioned, they can use little or no PrEP in some cases, and our goal with SCID is the same, is to minimize the preparative regimens that we use. Now, this, you'll probably be able to see it a little bit better on your own books. This shows myeloablative reduced intensity and non-myeloablative approaches, and it gives you some of the spectrum of the agents that are used. So take a peek at that to have familiarity with those regimens. Now, currently, for autologous patients, we have a couple of preparative regimens to keep in mind, something called CEM, carboisotope melphalan, that's used for neuroblastoma, and thiotepa cyclophosphamide. This is the classic tandem transplants that we're doing now as standard of care in the Children's Oncology Group. The Europeans are using Bumel, and sometimes I-131-MIBG is used for neuroblastoma as well. For CNS, there are carbo-thiotepa combinations, and then when we do that, we usually do 3 rescues in a row, and carbo-thiotepa etoposide can be a single procedure for CNS tumors. BEAM, look at that, think about it, that's a lymphoma protocol with the agents that you see there. These are the regimens that are typically used in autologous transplants. Okay, time to wake you up again. Case presentation. 6-year-old female who has AML, it's now day +9, still neutropenic, has a high fever, oxygen saturation 90%, fine, patchy bilateral infiltrate, blood pressure normal for that age. What's the problem? She has an infection. Now, I'm going to zoom right by this because Sung-Young presented it so nicely. Take a peek at this. I really like it. It encapsulates what Sung-Young mentioned about the phases: pre-engraftment, peri-engraftment, and late after transplant. I guarantee you'll have at least one question on that about when certain types of infections can occur. Now, keep in mind the transplant approach matters. If you have cord blood T-cell depletion or ATG use, it's going to take a while for the immune system to recover. If you get acute or chronic graft versus host disease, again, you're putting patients on immune suppression, and it's going to take a little while for them to recover. Another case, 3-year-old, day +16 after cord blood transplant. He has a fever, 39.5, skin rash on his trunk, palmar and plantar erythema, itching, no stools yet, normal LFTs, and key, no fluid retention or hypoxia. Now, if you look at this and you know a little bit about transplant, you'd think, oh, maybe it's engraftment syndrome, but remember, there's no hypoxia, no fluid retention, which oftentimes comes along with what we call engraftment syndrome. This is actually a case of acute graft versus host disease, so we always have to keep that in mind. It usually occurs before day 100. Oftentimes can occur near the time of engraftment, either right at it or within 5 to 10 minutes, or 5 to 10 days. Almost always involves the skin, but of course it can involve the liver and intestine. And it's a substantial cause of morbidity and mortality. This is a picture of the palmar involvement. This is skin rash. What you see with this is apoptotic bodies that occur in the glands, and this is a GI biopsy. So keep in mind, GI biopsy for graft versus host disease, you're going to see apoptotic bodies in the glands, and you're going to see crypt abscesses. So again, remember, apoptotic bodies and crypt abscesses are characteristic of GI graft versus host disease. This is an outline of acute GVHD staging. One important thing to keep in mind is the skin, liver, and gut are all staged independently, but what matters overall is the overall grade of graft versus host disease, because some graft versus host disease is more serious than others as far as causing problems, and usually gut GVHD is the hardest to treat and keep in mind. So these are definitions of that, but grading matters. If you have grade 1 to 2 graft versus host disease, which means you're going to have generally just skin disease, it's a lot better than if you end up with grade 3 or 4, where you're having liver and gut involvement. How do you prevent GVHD? Now, actually, Sung Young covered a little bit of this. The most common thing to keep in mind is tacrolimus or cyclosporin in combination with methotrexate. Some programs use MMF instead of methotrexate. A lot of other potential combinations are there. ATG is often used, sometimes sirolimus, sometimes prednisone, post-transplant cyclophosphamide, or complete removal of T cells. Primary GVHD therapy, if you have mild disease that's limited to skin rash alone, you just throw a little topical steroids on and optimize your tacro or cyclosporin level and move on, and usually that's all they need. But if you have progressive skin GVHD or multisystem disease, they end up getting high-dose steroids in order to bring it under control. If you don't see a response or you see worsening within 3 to 7 days, that's termed steroid refractory acute GVHD, and there's a whole bunch of things that I list here that we use in order to treat that, but it's very difficult to treat and can run your patient into all sorts of problems. Here's a case. You have an 8-year-old who's 6 months post-transplant. He comes to clinic, he has a rash on his arms and legs, dry, irritated eyes, and a persistent cough. He gets winded, he's afebrile, and this has been going on for a little while. So what should you do? Should you do blood for PCR, a BAL to rule out pneumocystis, PFTs and a high-res CT, galactomannan, or GI endoscopy? Hopefully you've all gotten the right answer, which is PFTs and high-resolution CT. Now, why is this? There's a whole bunch of things you could do, and you may want to do a BAL, depending on what his x-ray looks like. You may want to test for fungus, but this kid is screaming that he has chronic graft-versus-host disease because he has dry, irritated eyes and a skin rash, which are classic for chronic graft-versus-host disease. So again, it's usually diagnosed after day 100, but on occasion you can see it a little bit earlier, and all of these different things can occur. Involvement of joints, skin, mouth, and unfortunately pulmonary disease as well. This is a picture of some lichenoid changes on the face. These are similar changes on the hand, and this is a classic pattern for chronic GVHD on the back. Chronic GVHD, of course, can get better over time, and what you see here is that what I always tell patients is that if they get it, the median time to their chronic GVHD resolving is about 2 years. So they may need to be on immune suppression for a period of time. This I'll go through very quickly. Bottom line is it shows that there are certain factors associated with it. Younger patients do better. Patients who have advanced disease do worse, mainly because their disease can still sometimes come back, even if they have GVHD. Low Karnofsky does poorly, and low platelets do poorly as well. Standard therapy is prednisone with a very, very slow taper. Sometimes you need to take a year to get these patients off immune suppression. The median time of treatment I mentioned is about 2 years in responding patients. This is a long list of things that we can use to potentially treat chronic graft-versus-host disease, and many therapies are coming up all the time. 2 to point out here, ruxolitinib is a JAK inhibitor. That's been shown to be efficacious in chronic graft-versus-host disease, and ibrutinib got breakthrough approval for chronic graft-versus-host disease and can be used in children for that. Here's another case. You got a patient who had a transplant for CML, had a T-cell depleted procedure. He's day 145, and he's developed significant cervical lymphadenopathy and splenomegaly. So what are you going to do? You're thinking, uh-oh, he's relapsed, accelerated phase, he's got secondary Hodgkin disease, PTLD, toxo, transfusion-acquired HIV, and the answer is PTLD. Again, a key thing to keep in mind as a post-transplant complication is when patients have a highly T-cell depleted procedure, they are at risk for developing post-transplant lymphoproliferative disorder. It occurs within a few months after graft-versus-host disease, and it's associated with significant T-cell depletion. Its treatment is backing off on immune suppression, Rituxan. On occasion, we actually need to use cyclophosphamide. This will treat most patients, but keep in mind there are also what we call EBV-targeted cytotoxic T cells that can also be used to both prevent and treat this. So we're much better now at taking care of this particular complication. Another case, you have a patient with neuroblastoma. Day 15, you're preparing for discharge. The patient's engrafted, and you thought everything was okay, but all of a sudden they have some abdominal discomfort and discomfort and swelling with right upper quadrant pain. The bilirubin bumps up to 4. It's mainly direct, and they need oxygen. I think most of you know what I'm getting at, right? This is veno-occlusive disease or sinusoidal obstruction syndrome. Happens typically in the first 14 days of transplant, but neuroblastoma drives us crazy because it can happen up to day 28 and can sometimes happen with no increase in bilirubin. It's caused by endothelial damage, platelet deposition, hepatic congestion, and cholestasis. And it's been associated with cyclophosphamide, especially busulfan. This is the big bad actor, and with total body irradiation. And on occasion, if you combine sirolimus with other things, such as tacrolimus, that can increase the risk as well. What are signs and symptoms of veno-occlusive disease? Weight gain, right upper quadrant, hyperbilirubinemia, increased platelets, ascites, renal insufficiency, and pulmonary edema. Management is very tight fluids. These patients have marked capillary leak. You need to diurese them. You need to keep them negative, or they're going to have organ damage because of either abdominal compartment syndrome, or they'll need to be intubated because of their leak into their pulmonary space. Under that circumstances, often you need to maintain intravascular volume when it's difficult to do so, and CVVH has been used with a great deal of success with this. In addition, patients who have organ dysfunction associated with their VOD or moderate to severe VOD have been shown to benefit from defibrotide, and most programs are using that with efficacy. Another patient, this is 50 days out from his transplant. His GVH prophylaxis was tacrolimus, sirolimus, and is all of a sudden, out of nowhere, he's doing fine. His platelets drop. He has worsening creatinine and increasing LDH. A lot of alarm bells should go off. What we're talking about here is thrombotic microangiopathy, or post-transplant HUS is what it used to be called, but now what we call it is transplant-associated thrombotic microangiopathy. This usually occurs in the first 100 days. It's the result of endothelial damage that have been shown in some really nice studies that have been done recently because of complement mediated problems. So they become microangiopathic because of damage that's usually in the endothelia of their kidneys. And this, of course, results in schistocytes being produced because as the red cells go through the kidney, they're damaged. Now, the kidney is most often affected, but it can also affect lungs and the GI tract, so keep that in mind. You need to look at the smear and see schistocytes. You need to look at their urine, and you'll see a difference in their albumin-creatinine ratio, elevated LDH. All of these things can help diagnose this. It's been associated with combination of tacrolimus and sirolimus, TBI, high-dose busulfan, and active infections. There's some early evidence that eculizumab can help treat this, and many programs are using that again with good efficacy. Another case, very important complication that all of you need to understand very well. You have a patient 64 days out from TBI-based allotransplant. He shows up in the ER, he's confused. He had a seizure that was witnessed in the ED, and he can't see. So what's going on here? This is a classic presentation of posterior reversible encephalopathic syndrome. As you can see, you've got changes again in the occipital lobe. This again occurs after transplant and almost invariably is associated with uncontrolled hypertension, and the way you treat it is you control the hypertension. Many people, of course, will stop the calcineurin inhibitor that's on, either tacrolimus or cyclosporin. You control the seizures. They generally won't recur as long as the hypertension is controlled. And usually, again, if you can maintain tight blood pressure control, this is fully reversible and patients can live happily ever after. Now, I don't have a lot of time for late issues after transplant. The most important thing to keep in mind are second malignancies can occur, and this is oftentimes associated with certain diseases. For example, in Fanconi anemia patients or other patients who go to transplant to correct DNA problems, they're going to have a lot of second malignancies. Patients can have growth failure. This has been associated in the past with TBI, and especially when higher doses of TBI have been given to the brain associated with ALL therapy. In addition, endocrine issues can come up. The most important thing to keep in mind about this is that GVHD, especially chronic GVHD, is one of the most important associations with late effects after transplant. Now, indications, as I mentioned, transplant is used for cancer treatment. It's used for treating the bone marrow as it fails, and it's used for gene therapy. Now, you're going to hear more about cancer treatment, again, from the disease-specific folks. There's autologous and allo. When do you do one versus another? Autologous is whenever you can get away with it, which right now really is lymphoma, neuroblastoma, and patients who get brain tumor autotransplants. And the rest are allogeneic transplants. These are the indications. The other category, again, are those autotransplants we do for neuroblastoma and brain tumors, and these are the major indications in pediatrics. Transplant as gene therapy is used for only a couple of different things, but it's been tried for many. The most important thing to keep in mind where we know it works is with Hurler syndrome and X-linked adrenoleukodystrophy, as long as you transplant them early before their disease is too far progressed. Other particular diseases where we're looking at it is juvenile MLD, infantile Hunters, where it may have an effect, but it's still a little bit borderline, and epidermolysis bullosa. I want to finish by just spending a minute with CAR T-cell therapy. Many people have heard about CAR T-cell therapy. The key here in understanding this is you take T-cells that are autologous. Now, autologous could be allogeneic because you could have a patient who's already had a bone marrow transplant and the T-cells that are in them are from their donor. But remember, they're autologous because you take them from the patient. You then put a gene in which expresses a surface target, expresses a marker which binds with the surface target. You then have co-stimulatory domains on the inside that cause rapid expansion, and because of that, we've had great success in ALL treating these patients. Oops. The current indication for CAR T cells, and this may land because, again, we've got an indication here, are for treatment up to age 25 of patients with B-ALL that is refractory or in second or later relapses. Now, we're doing a lot of studies to try to move this further along. This results in 80 to 90% of patients with this very resistant disease going into remission. And many of them have long-term success without further therapy. But there's a lot of debate in the field about when you need to transplant these patients or when you don't. It's important to understand that a percentage of them will lose their CARs and they could have a CD19 negative relapse. There's an upcoming COG trial that's opening very soon looking at moving this further up. This is, again, a nice illustration of long-term efficacy associated with B-cell ALL therapy with CAR T cells. Finally, one thing to mention with CAR T cells, you need to keep in mind cytokine release syndrome. Many of you have heard a lot about this. I don't want to go into it in a great detail. Essentially, it's fever, potential of hypoxia, capillary leak that are associated with massive CAR T cell expansion. I don't think you need to know too much about it other than it occurs and you need to treat it, and you treat it with IL-6 targeted therapy or tocilizumab. You also need to understand that a portion of patients, approximately 40% undergoing CAR T cells, can have neurologic events. In general, those neurologic events have been reversible. So that was a marathon run. I think I covered pretty much everything we were supposed to cover. We don't have any time for questions, but I'm more than happy to answer any questions that people would have afterwards. So thank you very much.